Natalie Nunes. I am a consultant obstetrician gynecologist, which means I work in women's health. I work in London at a teaching hospital. We know that within the UK, we did not do very well. We had a rapid rise. We had a lot of deaths, and we are one of the countries in the top number of deaths per capita. But in terms of women's health, the presumption at the start of the pandemic was that pregnant women would be at higher risk. But that's actually hasn't really been the case. What is the case for any kind of condition affecting the lungs is that in the latter part of pregnancy, with the pressure of the baby on her lungs, she's not able to take as deep a breath, and therefore it can compromise her breathing a little bit more. So she may become symptomatic a little bit earlier. But our pregnant woman didn't actually do worse. The rest of it, we're really not sure. So anecdotally, we have seen a lot more miscarriages in the first trimester, women having no symptoms and coming for their 12-week scan and the pregnancy is not alive. We have had to, because ultrasound scan is quite a close contact. It's different. You can't do social distancing. You can't do a telephone appointment for that. So we had to do a lot of counselling of women over the phone. A lot of women distressed because we were not able to invite them in for ultrasound scans. So certainly in the early pregnancy unit, we were able to triage the kind of higher risk women and bring them in. But the lower risk women were not able to have the reassurance that a normal ultrasound scan could give them in early pregnancy. In terms of the rest of obstetrics and gynecology, it caused everyone in the department to have to think of different ways of working, which I thought was actually a really good thing. My colleagues, we keep a lot of women in hospital because we're too afraid to trust them to come back if something worsens or something changes. So a lot of women might sit on a ward for months of their pregnancy when actually they could be home. And because of COVID, it forced the team to institute more outpatient management. So women were given blood pressure machines, urine sticks, so they can measure their blood pressure and dip their urine, and telephone consultations, so talking to them, what are their symptoms, how they're doing, is baby moving, which we had to depend heavily on. And we didn't feel that there was any compromise of their care. So that was really good. But what concerned us is we know that domestic violence increases or starts in pregnancy. And when midwives meet patients and talk to them, they look at cues. How do they talk? How do they answer? Do they look away? Can they not look you straight in the eye? How they answer things. Talking to them when their husband or partner is not in the room and asking questions. They were not able to do that. And so there was a lot of concern that we might be missing women at high risk at home who are unable to divulge that they are having a problem in that regard. The deaths that we've seen in early pregnancy, the fetal deaths, these women haven't declared any symptoms. And it's difficult to it's difficult to try and predict or to work out at this point whether these were patients who had mild symptoms and therefore had COVID, because usually by the time we made the diagnosis, they're very emotional. We don't go into a full kind of history of what symptoms they've been having over the previous 12 weeks. But there is a study going on across the UK where they created an app and they asked the population to just log in every day and say what their symptoms were. And they were trying to predict early symptoms, not just the fever and cough. So other symptoms that people may say, oh yeah, I have this today, but I'm fine. And then a week later, they actually do develop symptoms of COVID and end up being positive. And they're hoping, and then later on, they added the question, are you pregnant or not? And we're hoping that when they begin to analyze that data, we will see, okay, these are the bunch of pregnant women. What symptoms did they have and what was the outcome of their pregnancy? So we're hoping that we will get that information. Was it actually COVID related? Was it something else that we don't know? In terms of the pregnant patients that we knew for sure were COVID positive, the ones that I've seen or interacted with were in latter pregnancy. So we had women who came in labor, had a cough, we tested them, and they were positive. And most of them labored fine, delivered normally. There was no kind of impact on their obstetric outcome. And then they went to postnatal care and they went home. Those who wanted to stay in contact with their babies and wanted to continue to breastfeed, they were advised to wear a mask when they were interacting with their babies, and to wash themselves prior to feeding the baby. And so most of our women actually continue to keep their babies with them and to breastfeed them. And so far, we've not seen any sequelae of that. We know that the bonding of mom and baby in those, first few minutes, hours, days are so important that as a community, the maternity profession felt that it was still, the risk was small and the benefits of the bonding was high. And so women kept their babies. If I had unlimited funds to do research, I would want to look at how the virus is mutating and to make sure that any future vaccine takes into account possible mutations. We already know that there have been mutations of the virus, and we know that it's of the same family. So one of the vaccines that they're trialing right now is one that they had started making when SARS-1 was around, but it never got to the point of human trials because then the disease settled down and it wasn't spreading, and so funding got pulled. And so when COVID started, they looked at it and they're like, okay, it's not too dissimilar, and they modified their vaccine a little bit, which is why they were able to go so fast to human trials. So I think that it would be important to kind of consider other mutations and make sure that any vaccine that is created is broad enough to encompass when the virus mutates further. My advice to the public at this time would still be to stay home unless it's necessary. Wash your hands as often as you can. Consider your clothing when you come home and where you've been. Have you been sitting on a bus, on a train where other people have? Have you been holding onto the bus handle where somebody with COVID might have touched? And as you come home, about changing clothes and washing your hands as you come in the door. And to continue to wear masks and keep distance from people if you can. The problem with COVID is that it makes people sick, but they have a lengthy time of being contagious and not having symptoms. So I presume everybody I interact with could potentially have it. My biggest concern is a second wave. And we know that part of why SARS-2, which is COVID, spread all over the world is because of travel. And we know it's because of travel and because patients are initially well for quite some time before they become unwell. And the number of people who've had it and recovered is not sufficient to provide herd immunity, meaning there are enough people who are immune in the population such that those who are not immune have enough immune people around them who will therefore not transmit it to them. It's not sufficient at this point in time. We've not had that number of cases. And the other challenge is we don't know how long immunity lasts after having had it. So therefore, we also don't know, even if there is a vaccine, how long will the immunity last? Some hospitals started antibody testing for their members of staff, and they were doing it at regular intervals. And there were people who had swab positive, confirmed COVID. They had antibodies the first couple of tests, and then after another couple of tests, they no longer had antibodies. And whereas other people continue to have antibodies. So we don't know. And I think we will have to live with this and coexist with it. And I think it'll be challenging. I think international travel will be challenging. I think the finance, businesses, restaurants, I think everybody has to start thinking of different ways to either run your business, different ways to live, different ways to take care of other people, to teach, different ways of doing everything to continue to protect us, because I think it's going to be here for some time.